75 years old female presented with chief complaint of vertigo, anorexia, vomiting, generalized weakness and headache since last 3 days with history of fall down 2 days back. On head.
What does it indicate?
Sir, first age.
Does it indicate the toxicity or side effect?
Yes, sir. GI side effect.
So yet you have not come to a toxicity.
Yes.
Right? These are all side effects.
Generalized.
Which is the first thing to come?
Anorexia and vomiting.
And vomiting. Okay, go ahead. Which the things was lacking. Now you know the paper is already know people know it. Yellow screen vision.
Specific but not.
Whatever that, if that is there,
That-
immediately you will see that
You will
big
see
drugs are going on.
Yes. Right.
I have seen plenty. Because we have used plenty.
So on examination, pulse was 44 per minute, blood pressure was 180 by 70 mmHg. On RS examination, it was bilaterally clear, NNP was present, and saturation was 98 with true net.
એક્ઝામિનેશન માં તો કેટલું બધું કરવું પડે મના કરવું
Yes, sir. Short case presentation.
પણ આપણે ડિગોક્સિન રિલેટેડ ડિસ્કશન હોય વર્ટિગો ફોલ ડાઉન હોય તો બે ત્રણ ઇમ્પોર્ટન્ટ પોઈન્ટ છે
અને
રેગ્યુલારિટી
CVS
લખવી પડે
RS એક્ઝામિનેશન કોઈ
CVS
CVS
એક્ઝામિનેશન નથી
CVS તો મેં આવી ને એની અંદર
આ શોર્ટ કેસ છે, લોંગ કેસ નથી. એમડી માં શોર્ટ કેસ આવતો.
Yes, yes, but આમાં આ તો કેવું ફોલ ડાઉન આવ્યું એટલે CNS તો ઇમિડિયેટલી ઇન્વોલ્વ થઈ ગયું
Yes, sir.
એઝ અ કોઝ એઝ અ ઇફેક્ટ
Yes.
જે બી હોય તે બરાબર તમારે એટલીસ્ટ યુ નીડ ટુ મેન્શન કે નોર્મલ લખી નાખવાનું એટલે વાત પૂરી થઈ જાય બરાબર કે ભાઈ ગમે ત્યારે તમે હાર્ટ પર જ
આમાં
ફોકસ કરો
CVS લખે ને તો કેસ ઓપન થઈ જાય એવું હશે CVS નહીં
અને પલ્સની રેગ્યુલારિટી ઇરેગ્યુલારિટી લખવી જ પડે તમારે ચાલે નહીં ના
જોવાનો સમય છે કોઈ પાસે. સીધો કાર્ડિયોગ્રામ જોઈ જાય.
ઇકો ઇકો
એ
હવે તો કાર્ડિયોગ્રાફી ઇકો પડે હવે તો ઇકો ઉપર આવી જાય
તમે ECG તો બોલતા જ નહીં હવે ECG નહીં આવતું
અને તમે ફર્સ્ટ યર છો સેકન્ડ યર
First year.
ફર્સ્ટ યર હજી થર્ડ યર પાસ એટલે સીધી એનજીઓ ઇકોય નહીં
અને સાહેબ આજે બધાને HRCT થયેલા હોય છે એક્સરે ચેક હોતો બી નથી મોટા
કઈ નહીં તો
Regarding past history, patient was known case of heart failure with reduced ejection fraction, hypertension, and with history of admission for atrial fibrillation with fast ventricular rate. Patient was on medication for same, tablet amiodarone 200 mg/d, tablet Digoxin 0.25 half OD Monday to Friday, tablet Apixaban 2.5 mg/d, tablet Cardivas 3.125 mg/d, tablet Digoxin 10/50 1 OD. So this was the ECG of that patient. This ECG showed the functional escape rhythm with heart rate of 45 per minute, with QRS complex are narrow of duration of 76 milliseconds without identified P wave on the tracing, and there is non-specific asymmetric P wave changes in the V1 to V6.
પેશન્ટને એસ્પિરિન કે સ્ટેટિન નહોતી ચાલતી
atrial fibrillation.
On investigation, serum creatinine was 2.75, serum potassium was 5.80, serum digoxin level was 2.25 nanogram per ml, CBC and thyroid profile was normal. Echocardiography suggestive of dilated LALB with ejection fraction 25% with moderate MR and moderate TR with mild PEH.
It was well normal.
Yes.
You are putting a complex situation. See, her creatinine is really very high.
Yes.
Her potassium is very high. Right?
Yes. hypokalemia.
right? So here on the contrary there is a
Potassium was
increase.
So that can be effect of digoxin itself.
So any old age person, like in this case 75-year-old female, presenting with GI complaint like anorexia, nausea, vomiting, along with CNS effect like weakness, vertigo, dizziness, and cardiac effect like on examination like bradycardia or any supraventricular tachycardia, present on tablet digoxin.
Which is the characteristic ECG rhythm in a digoxin toxicity?
Most common is
if you find it in the digoxin toxicity,
bidirectional
PAD will block.
Inverse tick marks.
PAD will
effect
block.
that leads to digoxin effect inverse.
No, paroxysmal atrial tachycardia with the block.
એટલું નોર્મલી લેવલ હોય
Previously it was 0.5 to 2 nanogram, but the current guidelines is 0.5 to 1 nanogram per ml is the therapeutic level.
So it is not only digoxin, it is a complex problem.
Complex,
Take it from me.
amiodarone, beta blocker, so
That drug has got narrow therapeutic window,
yes.
right? Efficacy and toxicity very narrow.
So in this case, patient was on digoxin level with complaint of GI and some CNS and some cardiac. So we have to suspect that patient might have digoxin toxicity, which will be precipitated by other heart rate blocking drug like beta blocker and amiodarone.
And which was being protected by the hypotension.
Yes.
Otherwise,
Hypokalemia precipitated the condition.
so it is a complex situation is going. On one side, digoxin toxicity is trying to come, and the high potassium is trying to stop it as such. In good old days, we were giving the potassium for digoxin side effect.
So, cardiac glycoside. Cardiac glycoside are the organic compound which contain the glycoside, sugar and common steroid nucleus that act on the contractile force of the cardiac muscle. Because of their potency, crystal.
Which is that sugar? Lactose, right?
That act, because of their potency in disrupting the function of heart, most are extremely toxic. The most common pharmaceutical product is digoxin. Other preparation available are digitoxin, oilbin, lanetoside C, eslenoside, and gitane. So, source
And
of
the brand is of which company?
Lennox.
Digoxin is brand of which company? Burroughs, right? Who are the competitor? Sandoz. Sandoz. Sandilinide. Right? And then the pharmaceutical war started coming. That it is the bioavailability of the digoxin is more important. So you can't replace digoxin with sandilinide. You may not get the same efficacy and same toxicity between two drugs. This was the pharmaceutical theory.
ઘોડા છાપ હતી કેવી હતી ઘોડાની સાઈન વાળી હતી
Ah,
એ લેનોક્સિન કે
એ લેનોક્સિન.
લેનોક્સિન
Burroughs company. Burroughs company.
ગ્લેક્સો નહીં ગ્લેક્સો
It's the original drug of the original. ये જુદી વસ્તુ.
તો તમે આજે કોન્ટ્રાક્ટાઇલ એક્શન મિકેનિઝમ ઓફ એક્શન છે એમાં કયા પંપને
Sodium potassium it is so regarding sources, plant sources are digitalis purpura and digitalis lanata.
Lanata is more important. Everything comes from Lanata.
Yes.
Who found out that? William Withering.
William Withering, an English physician and botanist, described the use of foxglove plant digitalis purpura for the treatment of heart failure.
How he found out?
He initially it was found epidemic, it was called dropsy for edema. So it was helping in reducing the
Who
edema.
was giving it? It was the observer. Old lady was giving. एक lady आती थी. So that the observation is more important. This observation of seeing that એટલે ક્રેક કઈ આપતા હોય કામ થતું હોય તો આપણે ઓબ્ઝર્વ કરવું પડે.
પણ સાહેબ આ તો ઠીક છે ડોક્યુમેન્ટેડ છે પણ આનું હજી ક્યાંક ટ્રેસિંગ કરો તો ક્યાંક ચડક સંહિતામાં અપાતું હશે આ વિધિ પણ એ ક્યાંય ડોક્યુમેન્ટેડ કદાચ નહીં હોય.
So pharmacology and mechanism of action. It has mainly it acts via main three mechanisms. One has positive inotropic action, second is neurally mediated action, and third one is electrophysiological action. So first, positive inotropic action. Digoxin is cardiac glycoside that binds to inhibit sarcolemma-bound sodium potassium ATPase pump. This ATPase pump catalyzes both influx of 2 potassium ion and efflux of 3 sodium ion against their respective concentration gradient and energy provided by the hydrolysis of ATP. Now, digoxin act on that pump and inhibit sodium potassium ATPase pump. So that will lead to efflux of potassium from that will inhibit the efflux of potassium from the cell and in proportion to the extent of inhibition of the ATPase and increase in the internal sodium ion concentration at the inner face of cardiac membrane. So sodium concentration will be increased in the internal cell membrane. So this local accumulation of sodium causes an increase in the free calcium concentration via the sodium calcium exchanger. This free cellular calcium concentration is responsible for the inotropic action of digoxin, secondary to the release of calcium from the sarcoplasmic reticulum. Now, positive inotropic effect on the intact ventricle or isolated ventricular muscle result in increase in the rate of rise of intracavitary pressure during isovolumetric systole at the constant heart rate and aortic pressure. That is present in normal as well as failing heart muscle. That will shift the ventricular function, means Frank Starling curve, upward and to the left, so that more stroke work would be generated at a given filling pressure. So it acts on the sodium potassium ATPase pump that will lead to increased intracellular sodium concentration and that will eventually lead to increased intracellular calcium via the sodium calcium exchanger.
What is this?
Cardiac marker sarcolemma.
There are 3 things. We are talking of basics. Then basic goes to the bench. At present we are on the bench. And then bench goes to the weights. I hope you understand me. Basic to bench, bench to weight, and then weight to basic again. We learn by this way. Some abnormality found, we search at the basic level.
Neurally mediated action. It increases the mean arterial pressure, foramuscular register and venous tone in normal human subject, probably in part because of direct but transient effect on the vascular smooth muscle. Patient with heart failure respond with decline in heart rate and other effect consistent with enhanced baroreflex response. So neurally mediated action is mainly mediated through the enhanced baroreflex response. Therefore, digoxin has parasympathomymetic action, clinically manifest as increased central and peripheral vagal tone. In heart failure patient, digoxin also has anti-sympathetic effect, which it also restores the baroreceptor sensitivity. Electrophysiological effect. Major effect of digitalis preparation on cardiac rhythm is believed due to modulation of autonomic nervous system. At the therapeutic level of digoxin acts by enhancing both central and peripheral vagal tone. These actions are largely confining to the slowing of sinus node discharge rate, shortening of atrial refractoriness, and prolongation of AV nodal refractoriness. It decreases the automaticity and increase maximum diastolic potential. That effect can be blocked by the atrophy.
How much? How much effect of digoxin will be blocked by atrophy? beyond heavy load.
Yes.
So it affects is block supra-heavy.
Super. Effect on Purkinje fibers, it decrease the resting potential, decrease action potential duration, and enhance the automaticity by increasing phase for repolarization. Now pharmacokinetics, the elimination half-life of digoxin is 36 to 48 hours in patient with normal renal clearance. This permits once a daily dosing in patient with heart failure. It takes 1 week duration to achieve near steady state blood level after starting the maintenance therapy. Digoxin is excreted by kidney with clearance rate which is proportional to the glomerular filtration rate. In patient with congestive heart failure with increased renal blood flow and cardiac output with vasodilator therapy and or sympathomimetic agent may increase the renal digoxin clearance. Conversely, half-life of digoxin can increase in patient with advanced renal disease up to 3.5 to 5 days. So the drug should be cautionally used in patient with advanced age and renal failure. Oral
Ideally, it should not be used.
Yes.
There are hardly any indication of digoxin today. I agree. But there is a
પહેલા જ્યારે 3D થેરાપી આપતા ત્યારે દેતા હવે તો 3D નીકળીને 5 પિલર આવી ગયા.
there are better drugs available for the same situation. See, you leave the old, come to a new one.
So digoxin has many drug interaction. Drugs which cause increase the digoxin level like spironolactone, erythromycin, gentamicin, tetracycline, quinine, atropine, indomethacin, verapamil and diltiazem.
If you give spironolactone and digoxin, what will happen?
Spironolactone will cause hyperkalemia, so that will
What will happen to patient?
sorry,
Gynecomastia.
yes, gynecomastia.
What drug does steroid?
Yes, both have steroid.
Right? So there is an increased incidence of gynecomastia once you give aldactone with the Digoxin.
Drugs which decrease the digoxin level, antacid, phenytoin, pentazocine, neomycin, adrenaline, salbutamol, rifampicin, metoclopramide and penicillin. Now indication. At current, it is used in heart failure and atrial fibrillation. In heart failure, it is class 2B indication in which the heart failure with reduced ejection fraction and persisting symptom NYHA class 2 to 4 despite treatment with beta blocker, ACE inhibitor and mineralocorticoid receptor antagonist. And second, it may be considered to reduce the risk of heart failure hospitalization in patient with sinus rhythm with EF with reduced ejection fraction who are unable to tolerate beta blocker, and patients will also receive an ACE inhibitor and MRA mineral receptor antagonist simultaneously.
આઠ ની આયા પછી બધું ઓછું થઈ ગયું.
Yes.
Does it hold true today also? અંદરની ગાઈડલાઈનમાં છે ડિગોક્સિનનો કામ ક્યાંય નથી.
યુરોપિયન છે. લોયર નથી ત્યાં આગળ. અમેરિકન હોય તો લોયર આવી જાય.
And second is atrial fibrillation. Atrial fibrillation is present in 30% of heart failure patient. At rest, digoxin can effectively control the ventricular response in atrial fibrillation by enhancing the vagal tone. However, it may be less effective at controlling ventricular response during exercise or in the setting of enhanced sympathetic tone. In patient with heart failure and reduced systolic function, the combination of digoxin and beta blocker reduce symptoms, improve ventricular function and leads to better rate control than either agent alone.
So why it is less effective in controlling ventricular response during exercise?
It acts mainly on the sodium potassium ATPase and which will be in the
તો તમે સાહેબે જે કોમેન્ટ કરી તમને સમજાણીને કે વેન્ટ્રિકલ એટ્રોપિન તમારી પેલી ઇફેક્ટ નથી કરતું વેન્ટ્રિકલ પર આ બે reason same છે શું same છે reason?
It acts above the AV node.
Why? Because vagus nerve fiber ventricle સુધી ના જાય. Okay. Because it's parasympathetic myopathy થઈ જાય. બરાબર, હવે તમારી નર્વ ત્યાં જ જાતી તો ક્યાં ઇફેક્ટ કરશે?
In coronary arteries, it is not used because myocardial ischemia may cause inhibition of sodium-potassium pump, which will render myocardial tissue more sensitive to arrhythmogenic effect of digoxin even at lower doses. Now dosing. Most patients require 0.125 to 0.25 milligram per day as a single daily dose, as little as 0.125 mg every other day in renal impairment patient. Young patient may require as much as 0.5 milligram per day. In acute loading dose of 0.5 to 1 milligram, digoxin may be given by intravenously or by mouth. Serum digoxin level for compliance and digitalis toxicity, which are not routinely required if ventricular rate is controlled during the atrial fibrillation and there are no symptoms of toxicity. So dosing modification. Adjust maintenance dose by estimating creatinine clearance and measuring the serum level of digoxin. In heart failure, higher dosage have no additional benefit and may increase the toxicity. Decreased renal clearance may also lead to increase the toxicity. And in geriatric patient, use lean body weight to calculate the dose.
So pakka picture to develop the toxicity.
Yes.
75 years
Yeah.
female
Female.
with a chronic kidney disease
Yes.
with a high potassium.
Yes. So toxicity and adverse effect. So causes for the digoxin toxicity like suicide gesture or purposeful overdose, incorrect dosage, and risk factor for developing digoxin toxicity are renal dysfunction, in which moderate to severe renal failure, creatinine clearance less than 60 ml per minute in males and less than 50 ml per minute in females. Elder patient, female, and concomitant drug interaction. So that patient was having all the risk factors.
So why females are independent risk factors?
Lean body mass also is that.
So there is no separate dosing guidelines for female, right?
No. So mechanism, most of
That may be absence of bile. 2x. See, drug kinetics altered in male and female. And who controls it? X and Y.
So most of digoxin effect in heart failure patient is thought to be ANS modulation, but toxic effect are explained mainly by excessive sodium potassium pump inhibition. Toxic effect of digoxin occur when the cytoplasmic calcium increase to concentration exceeding the storage capacity of sarcoplasmic reticulum. As a consequence of this internal calcium overload, several cycles of calcium release reuptake are required to restore the calcium equilibrium between sarcoplasmic reticulum and cytoplasm. In addition, high internal concentration of calcium activate a depolarizing current which will correspond to the forward mode of the electrogenic sodium calcium exchanger. This current generates delayed after depolarization that give rise to extrasystole and sustained ventricular arrhythmia. The toxicity of digoxin could also be amplified in human heart failure because sodium calcium exchanger is upregulated in the patient of heart failure. Manifestation. Traditionally, toxicity of digoxin is divided into cardiac and extracardiac effect. So, define toxicity as nausea or vomiting with cardiac effects with resolution of side effect on discontinuation, and serum digoxin concentration is not a necessary criteria, but more than 2 nanogram ml will be helpful. Extracardiac side effects are non-specific but more common, in which GI symptoms are more common. Nausea, vomiting, anorexia, abdominal pain, diarrhea, malaise, lethargy, fatigue, neurological symptoms like dizziness, confusion, headache, visual changes like flashing lights, halos, color disturbance in green yellow spectrum, and blurred vision. Cardiac side effects are more specific but less common. almost any permutation and combination of heart block, brady and tachyarrhythmia are possible. The only dysrhythmia not assumed to be due to digoxin toxicity is Mobis type 2 heart block. Now, ECG feature of digoxin toxicity. The classic digoxin toxicity dysrhythmia combines supraventricular tachycardia due to increased automaticity and second slow ventricular response due to decreased AV conduction. Other common dysrhythmia associated with
I was talking.
yes.
PID weak block.
Yes. Other common dysrhythmia associated with digoxin toxicity include frequent PVC, which is the most common abnormality, including ventricular bigeminy and bigeminy, slow atrial fibrillation, any type of AV block, first, second, or third degree, AF with complete heart block and a junctional or ventricular escape rhythm, ventricular tachycardia, including polymorphic and bidirectional VT. Now, ECG manifestation. This inverse check mark is the effect of digoxin on the heart. So it will like check mark sign. It suggests that digoxin is working, not sign of toxicity. So digoxin effect on ECG is not a marker of digoxin toxicity. It indicates that patient is taking digoxin. The QRS ST morphology is described as slurred or sagging or spook or reverse stick, hockey stick or Salvador Dali's moustache sign. So some ECG abnormality. First, most common premature ventricular contraction in pattern of ventricular bigeminy. Paroxysmal atrial tachycardia with block and frequent PVCs. Bidirectional ventricular tachycardia in patient of digoxin toxicity. Now, pathophysiology. Why digoxin causes the toxicity and leads to multiple dysrhythmia? It may be explained by increased automaticity, which due to increased intracellular calcium, and second due to decreased AV conduction due to central and peripheral increased vagal tone at the AV node. Now, digoxin does not affect the QRS, and maximal therapeutic effect of digoxin is usually present before the ECG effect appears. Now, management of digoxin toxicity. If the evidence of toxicity is relatively minor, like symptoms of nausea, vomiting, then withdrawal of the drug is often only specific treatment required. If there is no evidence of serious cardiac problems such as heart block or significant dysrhythmia, then following the withdrawal of drug, the correction of electrolyte imbalance and symptomatic measure will usually suffice. Now, confirming the diagnosis. After clinical history and examination, plasma digoxin level should be measured at least 6 hours after the last dose, since that 6 hours at least time required for attainment of the steady state. Now, therapeutic range, previously it was about 1 to 2 nanogram per ml. Now, current guidelines suggest that therapeutic range is 0.5 to 1 nanogram per ml. Now, management of dysrhythmias depend upon the presence or absence of hemodynamic stability, nature of arrhythmia, and electrolyte disturbance. More serious evidence of toxicity, particularly with cardiac involvement, dysrhythmia is potentially life-threatening and requires admission to hospital. Major hypokalemia correction is required, intravenous sublimation of no more than 20 millimole per hour of potassium to reduce digitalis binding to sodium potassium ATPase, and more rapid infusion may lead to asystole.
This was past.
Yes.
Once antibody came, all this thing goes away. But not only antibody came, digoxin also goes away. Right at present, to search for that drug for antibody is a nightmare. Because digoxin is not there.
When patient is having heart block, atropine and temporary cardiac pacing can be used. Now, digoxin toxicity increases bradyarrhythmia. When patient is hemodynamically stable, observation and discontinuation of the drug is only required. When patient is hemodynamically unstable, we have to use bind antibody which bind to the digoxin and will help in the digoxin toxicity. Second, atropine and cardiac pacing may be used in hemodynamically unstable patient. Digoxin toxicity induces supraventricular arrhythmia. When patient is stable, only observation and withdrawal of drug is required. Short-acting beta blocker like esmolol may be helpful in supraventricular tachyarrhythmia with rapid ventricular rate, but advanced or complete AV block may be precipitated by use of short-acting beta blocker. If rate-related ischemia or hemodynamic instability is present, then digoxin is the treatment of choice. Calcium channel blocker are contraindicated because it increases the digoxin level. Premature ventricular contraction bigeminy or trigeminy may be observed unless the patient is hemodynamically unstable, in which case lignocaine may be effective.
Digoxin can be used
No, sir.
supraventricular tachycardia.
Medicine act on the AV modes.
Can be used upon
Why he is asking?
Digoxin toxicity માં નથી use. Otherwise SVT might be
SVT ની અંદર
SVT might be drug of choice, but not in digoxin toxicity. The mechanism different.
Because scenario is different.
Digoxin toxicity induces ventricular tachycardia, in which it will respond best to digoxin. Lignocaine and phenytoin may be useful because they decrease the enhanced ventricular automaticity.
અમે અવાજ્યા માતા કરતી છીએ અમે અવાજ્યા જ માતા હતા બીજી બાઈને આવ્યા પછી આ બધું બોલાઈ ગયું પછી બીજી બાઈને કર્યું અને ડિકોક્સિન કર્યું એન્ટીબોડીઝ
Direct current electrical cardioversion is relatively contraindicated because it may lead to life-threatening VT, VF or asystole, which can be very difficult to control. Malignant ventricular arrhythmia, in which phenytoin will be useful, and cardioversion is used only when required due to the risk of precipitating asystole and VT or VF. Role of magnesium therapy as temporizing antiarrhythmic agent until antibody is available, life-saving when VT or VF occur. IV magnesium sulfate 2 gram over 5 minutes. Then it will apart from successful replacement of intracellular magnesium, it acts an indirect antagonist of digoxin at the supraphysiological level. After initial bolus dosing of 2 gram, it can be continued on maintenance dose of 1 to 2 gram per hour. And magnesium level should be checked every 2 hours, and therapeutic dose is 4 to 5 mg per liter. For hyperkalemia, calcium is not recommended to treat hyperkalemia because ventricular tachycardia or ventricular fibrillation may be precipitated because already intracellular calcium is more. Sodium bicarbonate and or glucose and insulin are indicated. Digoxin antibody fragment for potassium level more than 5 mg per liter. And potassium binding agent are useful when hyperkalemia is present.
એ તો બહુ મોડું કામ કરે
So anti-digoxin antibody digoxin indication for severe toxicity, life-threatening arrhythmias, hemodynamic instability, hyperkalemia more than 5 mg per liter, digoxin level more than 10 nanogram per ml, altered mental status, ingestion greater than 10 mg in adults or greater than 0.3 mg per kg in children. Now dosing of digoxin, in which number of vials required for reversing the digoxin level, it will be number of vials equal to digoxin level nanogram per ml multiplied by weight divided by 100. So 1 vial of digoxin contains 40 mg, which will neutralize around 0.6 mg of digoxin. So home message: do not prescribe lanoxin unless guidelines indicated. It has narrow window between therapeutic and toxic concentration. Suspect toxicity in elderly, renally impaired patient on lanoxin with GIT plus CNS plus vision and rhythm abnormalities. Management of lanoxin-induced dysrhythmia and
just a minute. There is something like the whole lecture conflict of interest. conflict of interest in decision making. When you are having too many options, you are a confused person as such. Right? That should I buy the car? Should I use the sodium? See, glucose, insulin, drip. Means that when many options are there, you are confused. If the one option is there, you have got no option.
Management of lanoxin-induced dyslipidemia, atropine and pacing for unstable bradykardemia, lignocaine or phenytoin plus magnesium for PD or PM. Beta blocker may induce advanced AV block. Calcium channel blocker are contraindicated. Importance of electrolyte imbalance correction. Importance of hypokalemia correction. Indication and dosing of digibine and DC relative contraindication.
In nutshell, what I told is the conflict of interest.